Hello everyone, welcome to a new Process Mining Café. Today, process mining in healthcare, and I'm very happy to welcome two guests today. Our first guest is Fran Batchelor from UW Health in the United States. Hi Fran. And we are also joined by Luise Pufahl, a postdoctoral researcher at the TU Berlin. Hi Luise.
Hello.
Thank you both for joining us for today's discussion. Before we get into it, I want to remind you all that one of the nice things of these cafes is that we can talk with each other. So just below this video, you have a chat on this website where you can just type in your name and then you're in there and you can add any remarks, any questions that you have. And throughout the session, we will keep an eye on it, and every now and then in between take the questions into the discussion, so we discuss further among all of us. So yes, let's get started. So process mining is such an interesting application area for healthcare, and one of the reasons is there's a lot of potential, but also there are quite some challenges, and we will talk about this in more detail in today's session. One reason for this is that healthcare processes are not as simple and as linear as you would, for example, see a process when you apply for a passport, for example, right? Everyone is different, so there's a lot of individuality and a lot of variety in healthcare processes, which is one of the reasons why they're very complex very quickly. But at the same time, it's very relevant, and if you can make a process more efficient but also increase the quality for the patients, there's a lot of potential for this. And so before we get into all of these challenges and opportunities, I would like to ask our guests to introduce themselves a little bit about their background with process mining, and also how did you come to use process mining specifically in the healthcare area. So maybe, Fran, do you want to start introducing yourself?
Sure. So aside from my first job, working in a movie theater, selling popcorn and tickets and watching free movies, the majority of my career, or my entire professional career, has been in healthcare. When I was in nursing school, I worked in the admissions department of a nursing home, and then also on the switchboard in a hospital. After I graduated, I worked as an inpatient nurse in labor and delivery. And then during that time, I went back to school to become a nurse practitioner. So as a nurse practitioner, I worked in community clinics, providing direct patient care. And eventually, my path sort of took me to the inpatient surgery department. So I worked in inpatient surgery, providing direct patient care for 13 years. And during that time, I became involved in the information systems, the electronic medical record. So unlike other hospitals in the United States, the surgery department was the first to have an electronic health record. And so I was involved in implementing that all the way from device selection, software selection, to training and implementation. And then when the rest of the hospital adopted the electronic medical record, I was also involved in that implementation. So that sort of started my interest in information systems and processes. So I started taking some computer science courses and informatics, and that led me to my current role as a nursing informatics specialist, which I've been doing for the past 8 years, supporting our surgery department and our wound and skin department. So all of the work that I've been doing around process mining has been within the surgery department arena. I was introduced to process mining with a course that my significant other Bob had recommended to me, that Dr. Van der Est had taught on process mining. So that's kind of how I started my interest in process mining, and I introduced it where I work, and so that's that's my journey there.
That's great. It's interesting. It sounds like that the introduction of the electronic patient system was for you the introduction to basically informatics and analyzing data. And usually it's the other way around, that that a process miner is going to look for data and then they're looking for these systems. But for you, it started the journey of looking at data. Interesting.
Yes, exactly.
And so maybe Luise, you, I think, knew about process mining before you started specializing in healthcare applications. Is this correct?
No, not really, actually.
Okay.
So because I actually have the other way around the career, I would say. So like I was studying first information system, and then I got into contact with the medical domain. So during my bachelor study, actually, I did a dual study program, and I did it with a pharmaceutical company. And so that's why I was naturally somehow always involved in seeing healthcare processes, and also how to check that medicaments are working right and so on. And then in my master, actually, I was visiting some hospital and did there as a consultant process modeling and analysis projects. And there I also analyzed data, but at this time I was not aware of process mining so much. So in my master's studies, it was starting that we also got involved with that, but not so deep at this time. So I rather used process modeling and also typical KPI calculations and so on. But then later I started my PhD and also did some postdoc time at the Hasso-Plattner Institute, and they developed a digital health study program. So you can find now there a digital health center, and they have a special program in the master, and I provided their process mining courses to students which had a medical background, but as well as a computer science background, and teach them process mining. And I also had the chance to get some medical log data, which the students could analyze and so on. And the Digital Health Center also got or had the opportunity to work together with the Mount Sinai in New York. And they gave us the opportunity to do a project with them. So when I was in the group of Professor Weske, we did a project to apply their process mining on a really, really big data set there. And that was my way to get into contact with the healthcare domain from an information system perspective.
Yeah, very interesting. Coming from modeling and then into process mining. And it sounds like the students today have the chance to already study specifically this combination, like analyzing processes with process mining in healthcare through these studies.
Yeah, definitely. They are much more involved. So this program, and I think that's also another university now set up, that they do a lot with data and working on data mining techniques, machine learning techniques, as well as process mining techniques to help the healthcare system or the healthcare environment to improve there.
Yes. Okay, very good. Well, thank you both for this background. I think that's a good starting point to go a little bit more into the specifically the application of process mining to healthcare. What does this mean? What are the challenges, but also the opportunities? What we agreed before this session is that we will go through the main phases of a process mining project, and we will discuss the specific challenges that you encounter and also the questions that you have to answer for yourselves as a process mining analyst in these different phases. And the first phase is what you could call a scoping phase, right? So in this phase, as a process mining analyst, you need to define where does the process start, where does it stop, what do you see as the case, as the activities, and so on. So how do you want to look at the process? So I'm curious, Fran, when you work together with the department where you want to analyze the process, how how does this usually start, and how do you go about this scoping?
So, right. So usually it starts with a problem, an issue, that they are interested in learning more about what's actually happening, or how they are meeting their key performance metrics. So I like to start out with their understanding of the problem and then what questions they're trying to answer. And then from there, in terms of an ID and where the process starts and ends. So in healthcare, most of the projects that I've worked on, I either take the patient perspective, so the process might end from when the patient is admitted to when they're discharged, or the case, the surgical case perspective. So for example, maybe a starting point would be when the case is created, and then when the patient is in the OR. Or another example was the OR room perspective. So what was happening with the surgical suites on a given day? How many cases were passing through that OR? What were the timings between patient in and out, and kind of any delays between, because in surgery it's all about patient safety and efficiency, moving, getting patients to the right place at the right time. Right. And then looking at that way might be from when the surgery starts, when the first patient in, first patient out, as that.
Yeah, so that would be a typical view when the scope of the process is the planning of a surgery. So maybe the replanning is part of it, but once the surgery is over, this process view would be finished.
Right.
Yeah, I think that's also the perspective that you took when you talked about some of the analysis that you've done at the post-mining camp 3 years ago or 4 years ago, right? So that's also the surgical perspective.
Yes.
That you're taking. Yeah. Maybe just one quick follow-up question for that. So you said that you start out with the questions that people want to answer, or the maybe problems that they have. Can you give an example for what these types of questions are? Because they probably help also to define the scope in some way.
Right. So an issue could be that it's the perspective of some of the service lines that they aren't getting access to the OR. When they're requesting a case, they aren't able to get their cases on the schedule in a timely manner. So it might be questions like that, or issues that they are being confronted with as operational leaders. And sometimes the problem that they see changes as we start to look into the data. And so kind of it's fairly, it's not real common to have a clear sense of what the issue is until we start looking at it more and doing the iterations through the data and looking at it more. And then as a result, we're able to refine what that issue and problem is.
Yes. Yes, that's, I think, also, was nicely shown in the example that you shared with us on the blog 2-3 weeks ago, right? Where you showed a typical, it was more about the data transformation in this case, but the initial question was a very clear one, that people felt that they maybe needed more time in a certain room that they had allocated for their surgeries. But ultimately, looking at the data, actually, like you just said, sometimes more questions come up, or it becomes more difficult once you start looking at the data, because it appeared to be more complicated than what they initially thought the problem was, right? So what the problem was actually shifted through the analysis.
Exactly.
Yeah, and also what I'm hearing here, and that's I'm curious, Luise, how that's your experience in terms of the scoping of the process, because looking at healthcare, there's on the one hand side the diagnosis and treatment processes that patients go through, but then there's also the more scheduling type of processes, which are kind of logistical, right? And all of this interweaves. And so what's your experience? How to define the scope?
Yeah, so healthcare processes are really interesting because they are somehow big logistics systems. So you have to bring patients from one place to another, and that's maybe special for them. I mean, if you want to see the quality of care and how things are usually done with patient, then you would rather look on what events are related to a patient and maybe also to a special visit of him or her. Because then you want to see what are the typical diagnoses, what are the typical treatments which we have got, and so then you would focus on that. We found it always helpful to also study medical guidelines at the same time to find the start and the end point of such treatment processes. If you want to know more about the efficiency of a system, then you would rather do a different perspective, that you think about where are start and end points, or where is a patient entering in a certain system and where is he leaving. If you, for example, look at the OR, because then you would study rather the logistics behind it, and where are waiting times, and where have the patient laying around, or where are problems, bottlenecks, and so on.
Yes, exactly. Now, so one thing based on what you're saying is that using the medical guidelines to help define the scope of the process is also really interesting, because it shows that it's not unusual. You have this in other post-mining analysis as well, but it's for any process analysis that you go into, you have to have some understanding of the process that you're analyzing, right? And having the medical guidelines define the expected steps can help define the scope for the process that you're looking at.
Yeah, exactly. Yeah, the nice thing about the healthcare is that lots of data exist, really a lot of data, because healthcare systems are also forced by the government and by the insurance companies and so on, that they store a lot of data. And that is good, but also bad for process mining, because then you have a lot of data available where you have to select which is relevant for you. Yeah. And for us, the medical guideline helped to identify what are the relevant events we have to look at. Yeah, yes. Especially if you are not the domain expert, then it really can help. Yeah, and especially, also talking to the domain experts.
Yeah, exactly. Yeah, so we're coming back to the data question specifically in a little bit more detail in the second phase, but before we do that, maybe coming back a little bit more about the goals or the trigger for the analysis, right? Usually there's some reason why you want to do the post-mining analysis, like the example that Fran that you mentioned is that people in these surgery departments maybe want to feel that they that they don't get their cases on the schedule, for example. So that was one concrete trigger. I'm curious, Fran, from your experience, are these typically kind of long-term questions that have been there for a long time, or are there sometimes also kind of emergency analysis? So one of the people in the chat are asking us, is there sometimes, for if there's a specific situation right now, is this something where you can do an analysis in this moment, or is this usually something that's more long-term?
So actually there are a number of rapid improvement events that we take part of. And so that could be an example of an issue that we're trying to solve relatively quickly. So it's actually can be a variety, something that's long-term. When we talk about access to the ORs and block times, that's actually in the industry, that's a well-documented ongoing problem that many institutions struggle with. But there are certain things that we can target for rapid improvements, like trying to avoid late time starts and analyzing kind of some of the process steps for preparing a patient for surgery. So just focusing on a small area of the overall process and to target that. And then first, like with process mining, is to again, to get a baseline of what is really happening, and then helping to drive where to focus.
Right. So that sounds like in this situation, the scope would be particularly small and maybe deliberately small to focus on some tiny area to see whether that can be optimized.
Yeah, exactly.
Yeah. Okay, great. One other question that we got in the chat is like, what is the typical start and end point for a surgical process? You said it a little bit already, but can you maybe once more give this as one example where from the process from the very beginning to the very end?
So probably like very high level, the kind of the big milestones, if you will, would be the patient arrives. So they can arrive either from the outside, from their home or other place, or from an inpatient unit, and then they are prepared for surgery. So we call that the pre-op phase. So high level, that would be the pre-op phase, but with multiple steps within. So it just depends on the level of abstraction that you're looking at. So then the next big milestone would be the patient in the OR, and then the patient in recovery, and then discharged either back home or to an inpatient unit. So at a very high level, those would be kind of the key points that we're looking at when we're tracking a patient through the perioperative process.
Right. Yes.
Yep. It could even start in pre-op or in the pre-operative phase before the patient is in the hospital. So again, it's kind of looking at what your issue is, what you're trying to answer.
Yeah, and it's what you want to see. Yeah.
Right.
Yeah, and also so one other question was like, are administrative processes or procedures taken into consideration when mining processes? And yeah, this is what you just explained. It depends on how you look at it, but also the whole scheduling part. It's an administrative procedure that's very central to this whole process, right?
Yeah.
Yeah, maybe we can also tell a little story here. I was also from time to time involved in OR processes, or also observed them. And I mean, especially this administrative process where you ask the patient, did you eat something beforehand? And then the patient is maybe not coming into the whole procedure because he has eaten or drank something beforehand. So that also means that the preparation beforehand must be really good to prepare the patient for the whole procedure, that you don't lose your patient during the whole process, and then you have not the surgery which you just have planned. Yeah. Therefore, it's interesting to look also at these phases beforehand.
Yes, and that would be one of the reasons, right? So if we are looking at reasons why the surgery actually couldn't take place, then you have to look a little bit before. Yeah. Okay. Yeah, so it's interesting that in a way it seems to be maybe easy, because in the way you could say, well, it's about the patient, so there's probably a very clear patient ID in the system somewhere. So you can just take the patient ID as the case, and then you're looking at the process based on that case. But yeah, it turns out that's not really that suitable, right? Because if you're looking at the case ID as the patient ID, then you're getting very long processes where over the lifetime of the patient, basically. And this is usually a way too big scoped. So you want to take a closer look at a more clearly defined scope, like surgery, maybe with the pre-planning of the surgery included or not, or a concrete diagnosis and treatment. And also, there's a lot of, and that's maybe a good place also to come to the second phase when you're looking at extracting and preparing the data. Then what makes it challenging is that the patient might not have just one illness or one surgery, right? Maybe there's different treatments that are going on. So selecting the right data is one of the challenges, isn't it?
Yeah, definitely. So like it depends a little bit what data you have available. But if you have a huge data warehouse and you have the luck that you have the patient always treated in your system, then you have everything about this patient available. And then you have to start what to include in your analysis and what not to include. And usually data warehouses are organized in that way that you have the patient and then you have several visits connected with them. And for this visits also encounters, if I'm right here. And then you have to select on which level you want to look and what you want to select for your analysis.
Yes. Yeah, exactly. And that's, again, a place where actually what you mentioned before, the medical guidelines can be help in selecting the right activities from the system, right? So I remember that was actually also the strategy that one of our Prosmining Camp speakers quite a few years ago. All the things that we are mentioning here, we are going to link them when we publish the recording, so you can watch those back or take a closer look at those references. But so what Bart was telling back then is also you look at the electronic patient record system, everything is there, so you're in a way in a lucky situation. You have the case ID as the patient ID, but then there's a lot of different activities, and to select which are the relevant ones that you need for particular analysis, you can use those medical guidelines as a selection criterion to select the right activities from the system. And another thing is that sometimes you do have to combine data sources that are coming from different systems, right? I understand, Fran, you are often combining data sets. Isn't this the case?
Yes, there are times where I will get information from multiple data sources that I combine into one event log. And so depending on where I get the information from, either that's combined by our analytics department, or sometimes I can do it myself if it's less complex.
And what are these data sources? Can you give some examples?
It could be from our operational database or our non-operational database. We can also pull some raw data from our dashboards. So those are the different sources of data that I've used thus far in my projects.
Yeah. And so what were some of the maybe biggest challenges with the data? So both of you, what would you say is the biggest challenge in the data that you've encountered?
Yeah, I can maybe start. So one big problem is usually the data quality. Fran can maybe also support the statement a lot, because many of the data is actually typed in by the medical experts by hand. So they do the activities and then they enter it. And sometimes you have the situation that you have an emergency case and things are happening and are really fast and you have to care for the patient. And then you enter and document the steps you have done much later. So we usually have timestamps where we cannot really rely on. Things are getting really better. So like with new systems, also support is there that people can automatically scan things and so on. But there's still a way to go. And so data quality really have to analyze, I think, usually in advance. And research and process mining is also providing methods there that we can cope with that. But I would say data quality and the details of data are challenging in the healthcare environment.
Yeah. To the details we come back in a moment, but the data quality and a lot of manual data, that's also something that I've heard before. So would you agree, Fran? Is manual data a challenge, or do you see other problems?
Yes, I would agree with the timestamps and a lot of the activities not being recorded real time. And so when I've looked at documentation that way, I've also included information that's input by the user and then some audit trail activities too when trying to reconcile some of those. I feel like too that sometimes just the issue with the software design itself lends some problems to extracting data, especially about patients. And as Luise mentioned, like the concept of the encounters. So sometimes it's not as easy to track a patient through different encounters. And so when trying to look at the patient as a whole that way, it becomes a bit muddy. And then, of course, the quality of the data in terms of duplicative input fields. So I'm thinking of the talk that you had at the last camp about legacy systems and code and certain individuals coming into the job and not really seen how that underlying code was structured. And so sometimes you end up sort of with people just adding on to the system without a clear understanding of the design and the structure. And so we run into some issues with duplicate fields that need to be reconciled, that we're actually pulling the right field that we want. And so once I gather the data, I find actually that the process mining tool does a really good job of sometimes highlighting some of those. And so it's a very good way to help clean up the data for me anyway.
Yeah, it's so interesting that you say, like, usually we think that manual data is the problem, but sometimes also the system data, can be really problematic, and then finding out which are the right fields to really contain this information that you need. Yeah, can be a little bit of an iterative process, and you are completely right. The data validation, so the data quality checks are really part of and a really important part of the process-mining analysis. So before any conclusions can be drawn, right? You do usually a lot of this already with the process-mining tool. That by looking at, is this what I'm seeing here? Yeah, can this be even real, right? So you're checking what you're seeing with your intuition and your understanding, and this is probably also where your background really helps you, because you're not coming at this from a data analyst perspective, but you also really do have this medical background to check.
Yes, so sometimes it's a matter of looking at the data that you have and saying, does this make sense? And then validating and cross-checking it against actual logs. Because before you take your findings back to the stakeholders for further discussion, you want to have faith with the data and not to lose their faith. Because stakeholders are going to know this really just looks off, especially for professionals that have been working in the field for some time, and in that environment, they have an expectation of what might look like and what is really kind of really off.
Yeah, yes. And do you do this typically together with them in kind of a dedicated data validation session with one of those domain experts?
Yes, absolutely.
Mm-hmm.
Oftentimes I'll say, after I do data validation, I'll go back to them and get their impression of how this looks to them. Does this jive with what you're seeing, what you're feeling, what you're hearing from your stakeholders?
Yeah, exactly.
Yeah, sometimes as a process analyst, I think it's also really helpful to see how people are actually entering the data, how is the data coming there. So I also like this process observation where you go through the process and see what is happening to be a little bit more sure how data is actually ending up in a system.
Yeah, that's interesting that you say that, because that's one of the key principles that lean practitioners are using, right? That they have to visit the shop floor, if you will. They go there and they look at the process to have an understanding of what the process looks like, that they're analyzing it. But you're completely right. Just being able to see how people are using the IT systems can also give you some information about how reliable the data is and how they're actually working with the systems. Such a good point, yeah. Actually, we got one, more of a comment, also maybe related to something that you said earlier, Luise, about that the data is getting more and more kind of closer to the time when people are actually performing these tasks, right? So the way I understood it is that previously, when, let's say, the doctor at the end of the day, they go into their office and they write down what they did this day, kind of completely documenting after the fact, that nowadays with the systems where you maybe walk around with an iPad or, any kind of digital devices, you're in a way closer to the process as it really happens. So in a way, you're able to more accurately document timestamp data, which usually, like in the classical systems, or the classical more financially more tailored towards the financial transactions kind of systems, where you in a healthcare setting, of course, it's very important that people get paid for the procedures that are going on. So that's usually very good, well documented. But usually the date when this actually happens is not so critical, right? So that's where manually entering some dates or after the facts can really shift the time when something really happens. So for process mining, of course, the timestamps are really important. So getting closer to the times when things really happened is interesting. And this is where Isabella mentioned something that I think is interesting. She said, first of all, is there any limit in data used, in the sense, like, is more data better? Or are there also some limits, maybe in terms of understandability? Like, can there be too much data, maybe? And she mentioned the topic of real-time location systems, where some of the systems are basically as a service automatically collecting data. And I can imagine this can be combined with these types of systems, right? That we were just talking about. So I'm curious, whether maybe Luise, also in your research, I can imagine this plays a role, doesn't it?
Yeah, so first of all, to mention something regarding the improvement of data, really that real-time data when it happens. So there's a lot of machines involved in the healthcare environment, so machines to test something on the patient, to monitor the patient, to do a laboratory test and so on. And these type of machines are much more integrated nowadays. So they usually have an interface, and that data can be directly integrated into the hospital information system. And so it is like, I think we are in the phase where it's slowly, or not slowly, but where it's starting. At some points, people can already use it. And I also heard, for example, a story where it was about the patient monitoring in surgery, where they didn't want to have it because then there were also sometimes data where the monitoring system did not work properly, and then there was data at entered side, like the patient is not breathing a lot, or with something with his heart frequency is not good, and this was not true, and so they didn't want to have it in the hospital information system. So I think there is the opportunity of having these data much more integrated, and also opportunities like that the system has a barcode or something around, or a QR code, and then you can really track where he is actually currently. But you also have to handle this data somehow. So that's why I think there's still a phase where we are coming from more manual data to these automatically generated data, which is then also at the end trustful, because you don't want to have data which is not correct.
Yeah. Yes. So it's interesting what's going to happen there. It sounds like that's a little bit still more on the research side, these types of data, right? For example, I think, Fran, usually the data that you have been analyzing, that's more kind of the classical health information system data, scheduling data, things like that, not machine data. Or did you look at machine data at all at some point?
Yes. So device integration or vital signs into the electronic record is pretty ubiquitous in the healthcare industry. So when I collect data, it's usually from devices, if it would be part of my analysis, and also real-time locating systems, like for staff and for equipment mostly, where we can do analysis that way. I haven't, that capability is, or that technology is certainly out there, and that's something that we use pretty pervasively. Yeah. I haven't myself done a lot of work with that, but there definitely is the potential for tracking, especially staff movement, when you're analyzing process steps. So a future goal.
Yes, I'm just, I think I'm realizing now that this example that you shared 2-3 weeks ago on the blog, one of the events in the data set that you were analyzing is patient in the room, patient out of the room. And I mean, these are these manually collected times, because it's exactly on the hour and the minute, or is it something that's somehow detected through a sensor?
Yes, right now it's manually collected, but it could be if we if patients were like Luise mentioned, if they had like an ID band, which is certainly out there. It's not something that our institution has adapted fully, or so we can't collect their track their movements that way. So, but there is that that technology is there. Yeah. And not sure how that looks in the future for us. Yeah, I mean, we get into all kinds of issues with patients, and so some of those are kind of big decisions in terms of patient privacy and things like that, and and the patient's preference. We have we work with patient representatives in some of the decisions that we make for some of those bigger things. So kind of plays into those decisions.
That's so important. I'm glad you bring that up. So that's interesting to hear. So you're actively working there with the patient, depending on their preferences also.
Right.
But Luise, you wanted to add something?
Especially I think also the United States are much more advanced in these topics because here we always have this discussion about privacy and so on, and definitely we also have to find ways there to balance these two interests. But I think that usually the United States is more advanced in all these things because they are more open to test out these things. And here in Europe, I think hospitals are also starting to try out things. But regarding privacy, we always have to look what is possible, and therefore it's slowly coming, but still some way to go.
Yes, and also such an important topic, right? And it's also interesting to see that there's also research going on to determine exactly like what kind of analysis can you do on certain privacy levels. So that the important thing is that people are really conscious about it and make a clear decision based on what's possible and justified, let's say, also for the purpose of the analysis. Yeah, so maybe, so let's come to the next phase, right? We were talking about the scoping phase, determining where does the process begin, where does it end, and what the main questions and goals are that we want to analyze. Then the actual data extraction and the challenges that you can find there in getting the data, combining different data sources, dealing with data quality, data privacy, like we just discussed as well. And in the third phase, usually, you're going to start with the analysis, but often also there, it's a little bit of an iterative process and not immediately all the analysis can be done right away for the reason that often these processes are very complicated. And so this complexity in healthcare processes is even more dominant than in regular processes for reasons like that every patient is unique, right? Often you can actually look at 1,000 patients and you have 1,000 variants because every patient has followed a unique path. If you look at exactly the sequence of steps that they have followed, depending a little bit on the process and the scope of the process that you're looking at. And this leads very quickly to a very complex processes. And we have like 3 brief examples here to illustrate this challenge a little bit. So I wanted to start by showing the BPI challenge data set. So you can see it here up on the screen. So this is one of the public data sets that are provided by the Technical University in Eindhoven every year that are anonymized but real data that people can analyze. So if you're interested in process mining analysis in the healthcare environment, but you don't have access to any of your own data, then that's something you can take a look at. The very first data set in 2011 was from a Dutch hospital, and the data that you see here is a very simplified version, right? So if we're just going just a little bit higher, for example, around 50% of the activities, then it's even already taking a little while, and we're going to see that already this still very simplified level where we are only seeing half of the activities and only the most important path, it's already getting this kind of big spaghetti process, right? So then you have to take you have to apply the simplification strategies that you also apply in other areas. For example, it can help to look at different segmentations of the data. So for example, often in the initial data set, maybe you have very different patients all together in the same process, but you can maybe make segmentations of different groups of patients so that then when you analyze these groups of patients separately, you get more meaningful analysis for these subgroups. So that's one strategy. Another strategy, and again, it depends on the questions that you want to answer in your analysis. Another strategy can be to focus on specific activities only, right? So for example, here in this case we have many different activities. So let's see, I think 624 different activities, but we can, for example, say, well, let's just focus on the consultations. So when the patient actually was in the hospital for a consultation, then we could just say out of these 600 plus activities, we're just looking at all the the consultations, for example. And if we do this, then we see there's just 16 out of these 600 activities are consultations. So if we say consultations, we will see, now this is a much smaller subset of the data where we can focus just on these particular steps in the process. So this would be one example. And so using these strategies in the process mining tool by making these segmentations, leaving out details can be a good way and is a necessary way to deal with this complexity, right? But it's not, sometimes it's not enough. And so to illustrate that, we have two examples here. One brought by Luise, where it shows, or it can be shown in the data that often, and we see it even here. So if we go back to the full data set and to the maybe activity statistics, you can see, if you're looking at the activity names, that they're very, very detailed, right? So there's not 600 activities for a reason. Or without a reason. You can see that, for example, if activities are locked down by a person writing down a certain activity manually, this can be one of the reasons why you get many different activities, because of slight manual variations. And so in one of your research projects, right, Luise, brought up here this example, you were looking at a back pain process. Can you maybe tell us a little bit more about this example, how you approach this?
Yeah, exactly. Yeah, we wanted to know, or the question was, how the lower back pain process is usually working, what kind of treatments are usually given in most of the cases, what flows are the patient going through. So we looked first of all for the diagnosis of unspecific lower back pain, and then we looked for the process, and as you can imagine, with the medication and treatments entered manually, we had also such a spaghetti process. First of all, we started to look at the events which we really need for the process or for the analysis, and therefore we also studied the medical guideline and then defined which are the events we are interested in. And so we had different medications where we wanted to look at, but then we recognized that the medications are usually entered really on a real, there you can see the examples that they are on a real detail. So you can not only see that it was a tablet was given from a certain medicament, but also in which doses, we also found different versions of that. Based on that, we then decided that we could use medical ontologies that we then can find ways of abstraction. Now we can also see an example what it leads to. So you can see the whole spaghetti model, and then it's now zoomed into one example.
Yeah, and that's a problem, right? Like we just said. So if you have, for example, not just the medicine, but also if it's 5 gram or 10 gram or 20 gram, you get different activities for each of those. So that's one of the reasons why you get these very detailed process maps. Yeah,
exactly. Yeah, and so we used a normalization and said then, okay, everything which is related to naproxen should be then one word, and then we even further brought it together, and then it was prescribed NSAID, so that we have only one. For several ones, we have only one activity type at the end. That was a manual approach where we detected how it can be done. But the good news is that these medical ontologies are available, so you can automatically read them out. You can there are interfaces to them, and you can use them, and then you can with the help of them automatically abstract your events to the right level what you need for your analysis.
Yeah. Yes, thank you for sharing that, and we can point also to the paper in the when we share the other links with the recording, so you can take a closer look at that. But I think that's a nice example, like how you have to sometimes also on the data side deliberately group and aggregate things to get them to a meaningful level. So leaving out details is not always enough, but sometimes you have to actually make this data preparation step to get the data to the meaningful level. Right, and the other example that I wanted to share is the example that Fran showed us 2-3 weeks ago on the blog is going the opposite direction, right? So sometimes it's not always that the data is too detailed and that you need to do some data preparations to group it and combine it together, but sometimes you also actually need to unfold certain activities to get a more detailed view, right, Fran? This is one of the examples where actually the standard view was not enough for the specific type of analysis that you wanted to do.
Right. So, the initial data pull was looking at from when the case was created to the case being put into a room where the surgery would be performed. So the perception was that services weren't able to get their cases into a room when they put in their case request, even though they had dedicated block time. So either they were using up their own block, or it wasn't available. There are other unblocked rooms that they're also able to schedule into. So just by looking at the most recent case created and then into the room, we wanted to look at actually what was happening with those cases. So we wanted to look at, kind of all the iterations of that requesting and then scheduling into a room. And what we found was that there were multiple times that the case was requested, the case date was requested and then changed. So there could be multiple times where it was various reasons, either with patient factors or what have you. But so what we found was that there were multiple reschedules and then multiple room changes during that whole process. So we looked at the audit logs of how often those changes were made.
Right. Yes, and I think that's such a good example because there's no, we should know that, but it's still sometimes easy to forget, right? As a process mining analyst, there's not one right view of the process. It really depends. And the previous view that we had here, the simplified view, there was nothing wrong with this process view for other types of analysis that would have been exactly the right level of detail. But for this specific analysis that you were doing for this particular department, the scheduling aspect was crucial. So you had to get visibility into this part of the process. So that required some data transformations to bring this detail into your analysis. And maybe, so this is, Fran, I think that's a nice kind of bridge even, and brings us in a way also back to the beginning of the whole, these 4 phases where we start with the scoping based on also the questions that we have. But once you do an analysis like that, right, then in the last phase, it's about, the analysis, but also the communication of the results. So how do you actually work with the department? I'm very curious how do you communicate with them? We already heard that in the data validation, they're actively involved. So you have a session there with someone, so they already get a sense of what you're doing. But how do you communicate the results of an analysis with these departments? Can you tell us a little bit more about this?
Yeah. So usually I start big picture. So a lot of stakeholders are interested in the stats, kind of the numbers. And I find that the process mining tool actually lays that out really nicely with the graphs that are actually there. So a lot of times I'll just take like a snagget of it and then add commentary to those graphs that are actually in the tool. And then also some of those different views, like events over time, if we're looking at how many kind of manipulations were going on with a particular case. So it kind of gives you a big picture of what's going on. And then I also do show the process maps because I think that really resonates with stakeholders. They right away identify those process steps, and then looking at the timing metrics for those is really useful too. And then kind of the different views, either looking at the mean or the median if we're seeing a lot of outliers to get a better picture kind of what's going on instead of just looking at the average always. And then a lot of times when I can, I actually have the tool with me. And if stakeholders have a question about a particular case, we could take, a deep dive into that to see what's going on with a particular case. So kind of a variety of methods to communicate the results. So it could be with a tool, or it could be snapshots from the tool and metrics in a PowerPoint presentation. So it kind of depends on who I'm meeting with, the audience.
Yeah, that's great. So it sounds like you start with the metrics, but then you do show some process maps also. That was one thing I was curious about, because maybe it's not so clear. I mean, medical staff, they are trained in what they do in the hospital every day, but they're not process analysts, right? They don't know anything about modeling processes or anything. But if you show them this process that they work in, your experience is that they do recognize what is shown and can relate to it.
Mm-hmm.
Yeah, usually if you also look at medical guidelines, it's often also use such activity flows or activity diagrams. Yeah. So therefore, I think medical experts are also used to this kind of things.
That's a good point. Yeah, so the medical guidelines and the definition in this visual way actually gives them kind of a process view and a process thinking.
Yeah, not everywhere and not each of them, but if you look at some, you can also see similar diagrams as our word looks like. I mean, not the standardized view, but like typical activity flow diagrams.
Yeah. So, sorry, please go ahead.
I agree with that too, because a lot of times visuals are used, and so I think introducing the process mining models, it captures that complexity better, whereas the visuals make it seem much more linear, sort of that common path, which is, whereas a lot of times we're interested in variations on that, because that's where we get into trouble. And then dealing with that variation.
Exactly. Yeah, I'm just thinking of Luise. In the beginning, you mentioned that you started out with modeling, so that would be the Visio view that Fran referenced just now, right? So probably going from that to process mining is giving a very different view, probably.
Yeah, definitely. When you are modeling, you are usually focused on the happy path. So, like, what is in the usual case, because you also. I mean, when I was interviewing people, they also told me all the variation, but then I tried to select the most common one and some of the problematic ones and try to capture them. But definitely with process mining, you have a more evidence-based view on what is happening, how often, and what are critical things, where are bottlenecks or issues happening. So therefore, process mining can really also give good opportunities to the healthcare domain. Also, it's not straight ahead, but if you start with that, I think it's very useful.
Showing the complexity, but also being a good starting point then for further analysis and improvements. Yeah, I'm still thinking about the medical guidelines that you just brought up again, and maybe that's also relates a little bit to who was it? I think Hilda was interested in coming back to the questions or the goals of the analysis. So, I mean, if you have a medical guideline that states a certain way that the process should be followed, right? So you have kind of a rule for how the process should be done. So conformance or compliance related questions that are relevant or that either of you looked at in your process mining analysis as well?
So in our project, that was also the goal that we wanted to do finally when we have then a useful event log ready, also the compliance analysis and compare. And it's not about like saying, oh, you did not follow this medical guideline. It's more about like understanding why are deviation happening there and what are also good reasons for them that maybe also you have some further information where the guideline maybe not so should be not followed and where maybe also the process can be changed that it can be better followed. But the world is much more complicated. Again, in healthcare, it does not exist one medical guideline for one disease or treatment. So there are several ones existing, and each healthcare system will select what is best for them and what they want to do, and that is a decision what you have to make at the beginning of such a process mining project. What is the best medical guideline, and then you can measure or you do conformance checking and can see where are deviations and why are they there.
Yeah, and you also need this flexibility, right? That's the point. You don't want to have every patient being forced into one specific path.
Definitely. Usually patients have multiple diseases, not only one thing, but usually you can observe that they also have other things, and then you also have to deviate from the guidelines. So that's very normal.
Yeah. Yeah, so Fran, are compliance questions, do they play a role, or is it more KPI-based questions that you have encountered?
Mostly KPI questions. So an example of something that we did look at was our performance in terms of the case urgency and getting the patient to the OR. So there's different levels from elective, where the time and date of the surgery can be scheduled at the patient's convenience and so on, or emergency where the surgery needs to happen right away to avoid adverse effects. So we did look at that, how well we were meeting that those metrics.
Yeah. That's a good point. We sometimes forget that when we talk about compliance or conformance, then people always think like following a particular flow, but there's also performance-related questions that are compliance relevant, right? So that's an example, right. I think. Sometimes things have to happen fast or fast enough.
Right.
Yeah, time constraints are really relevant. Environment in the healthcare system. You not only look that things has happened so and so fast, but also had they been stopped after an hour because something should only take 1 hour or other things. So time-related questions, and that's why data should be good, that you can check that as well.
Yeah, exactly. Yeah, I think it's nice that we end back up now in this kind of analysis and talking with domain experts who ultimately have to do something with those insights to improve the process, that we are talking again about the goals of the analysis, because of course that's what it is about. And maybe just looking at the questions or the input from the chat again, that was I think one of the questions. Let me see a little bit earlier. What the main where is it? Yeah, what the main areas? What are the top 3 goals that a process mining project in healthcare can achieve? So what are maybe? Yeah, I think you can look at it in terms of frequency, what are maybe the most frequent analysis questions that we see, but also maybe where are the biggest opportunities, where what process mining can contribute in terms of how these processes can be improved. So do you have anything to say about this question?
Yeah, I think one big thing is to have, with process mining, to gain an understanding of what is currently happening, and as Luise had mentioned, an evidence-based way of looking at that, of what is actually happening, rather than something that is intuitive or what we think is going on, but using a more evidence-based way of looking at it to understand what's currently happening. Because I think before you start any improvement project, you need to understand what's happening right now.
Yeah. Exactly.
Yeah, I think also that usually hospitals want to understand how this process usually running, because you have different experts involved, and every expert has his own way of also doing it. It's a typical knowledge-intensive process, and you can also learn from each other. So like by seeing that works very well, and that is a good way to approach it also on an evidence-based way, I think that can help. The second thing is definitely also to see how much are you using a medical guideline, how much are you complying to it, or where are deviations and why are there deviations. And then I think also this performance view to see also on a databases or with the help of data, where are bottlenecks, where are issues, where we maybe need new resources, where we need a change in the system to make it better. That I think the three typical questions what you have there.
Yeah, great. Okay, I think that's a great summary. And so I think also what it's maybe good to bring up once more is like what you see in the whole lean approach and lean or process improvement thinking is the idea that often if you can make a process better, it can actually also at the same time be made more efficient, right? It's not always like that you have two different goals that are opposing each other, but sometimes you can improve the process in one direction and improve multiple things at the same time. And I think in healthcare there are also interesting opportunities in this area. For example, I remember one project a few years ago. I was at a kind of a meeting. It was based on a Lean Six Sigma initiative, so it had nothing to do with process mining, but they were looking at a surgery process or a certain type of patient who got a certain type of surgery. And by actually analyzing the process, they could improve it in a way that the patient had to spend less time in the hospital. So rather than spending 6 days in the hospital, they only had to spend 3 days in the hospital, and the rest was done. The patient was at home, still recovering from the surgery, but through a mix of kind of support still from the hospital, they could do this at home rather than having to be in the hospital. And on the one hand side, this is was more cost efficient for the hospital, but also the patients were actually happier because they wanted to be at home rather sooner than later, right? So sometimes, of course, that's in healthcare, you're not just looking for saving costs or making something more efficient, but always the patient and the quality is really important. But often these things go hand in hand.
Yeah, I agree. Patient care or the quality is the first thing you always look in the medical domain, and then also other things play a role.
Yeah.
Right.
And that's also in your processes, Fran, what I have seen in these kind of surgical processes. That's always, if you can improve that, it's also good for the patients. They don't have to be rescheduled or.
Right. Yes. So while we might want things to go faster, we're also interested in the outcomes too.
Yeah.
And so sometimes it doesn't make sense to cut steps in certain processes. if we impact outcomes.
Yeah, exactly. And that's really important to keep in mind. And for that, you do need this understanding of the medical processes behind it, and explicitly have this as one of the dimension in your analysis, right? The quality of the outcome. So that needs to be taken into account deliberately, not to not to omit it.
Yeah, especially in surgery, you have a lot of steps which are related to so safetiness, patient safetiness. You have different checks, like in a flight, where you would have a checklist and you walk through it. Is it the right leg, and so on. So these steps definitely can be not cut out, and are very, very essential.
Exactly.
Okay, very good. Great. Yeah, I think it's nice that we ended back here in this, where we started with the goals and the opportunities that exist for process mining in healthcare. And it's exciting to see examples where process mining can really contribute to improving healthcare processes. So that's really great to see, and I think we will see many more great examples in the future. So maybe before we start, is there anything else either of you wanted to add or to say, or something?
I wanted to draw attention to a Higgs mini track, which I'm organizing together with Matthias Weske and Jorge Munoz Gama. If you are interested in that, then you can hand in your paper. I think the deadline was in mid of June. I think Anne will also link the website to it.
Yes, we will link it. So for the researchers who are working on process mining in healthcare, that's something you should definitely pay attention to.
And the track is also more application-oriented, so we are interested in where things applied, what is successful techniques, methods, and so on, where things have really been done in the healthcare domain.
Yeah, great. Very good. Perfect. Is there anything else you want to add, Fran?
No, just thank you for having me.
Thank you both for coming on. It really was very nice to talk about this with both of you, and I think it was interesting also you brought different perspectives on both process mining but also the healthcare analysis, and it was very good to talk with you about it. Thank you all for joining us in this Slack here today. We will publish the recording in 1 or 2 weeks or so, together with all the links as we promised. And that's it. So thanks a lot for joining. The next Process Mining Café will take place on Wednesday, 21st, April. And we will be talking about somewhat unusual data transformations. So what you can do if you don't really have process mining data, but you have to be a bit creative about making data that you can analyze. So see you again in 1 month. And thanks a lot again, Luise. Thanks, Fran, for joining us today. Thank you all. And see you again next time. Bye-bye.
Bye. Thanks for the invitation.